I think we are getting closer to reconvening because I see the sign that we are now streaming live on YouTube.
Senator Elmore.
Thank you so much, Madam Chair. Dr. Arano, I appreciate your testimony. I appreciate you staying with us till this late hour. We are close to about 10 hours of our public hearing. We actually even ran out of our YouTube space that we had to do it all over again, but it was worthwhile. And I wanted to just thank you for your written testimony. It's a lot of reference material, which is exhibits to share the rationale. Now, a lot of things that we've heard, we have basically looked at complete opposite positions and very strong positions throughout the day.
Oh,
Can we mute? Okay. Can we, here's the issue that everybody's been in complete opposite positions. And that's part of the challenge many of us may be having is that, but I can tell you, I know you well enough. I know that I can trust you as a surgeon, as a person, and like many of the other people. I want to try to find out what will be the middle ground. And I also wanted to clarify a few things because a um, number of individuals who came in, they spoke about to podiatrists. They said we have done 1,400, 1,500 surgeries in the ankle area, but they were not the surgeries that are in question. And I felt it, I didn't want to interrupt because it was in the conversations that other people were having. If you're going to explore that part as well, about the 1,400 some procedures that people say that they're doing in the ankle, but are they the procedures that they're doing? Because your documents are suggesting otherwise. Help clarify some of that for us. And also, in the end, if you can speak about the common ground, if there is any.
Sure. So I believe they're saying they did 1,400 cases during their residency, which would be foot and ankle cases. The vast majority of them would be foot cases. And I would ask you, if you were having somebody do a total ankle replacement on you, would you rather have somebody who did, 400 bunions and great toe elastic implants, or somebody who had also done 400 total knee replacements, total hip replacements, total shoulder replacements? What's going to prepare you better for total ankle replacement? What's going to prepare you better for doing a tibial pylon fracture? Fixing fractures of the first metatarsal, or fixing fractures that involve the articular surface of the knee or the hip or the pelvis or the shoulder. That's to me, that's very important. I mean, there's been kind of misrepresentation that, pylons are just like ankle fractures, like malleolar fractures. Malleolar fractures don't really involve much of the weight-bearing surface of the joint. They're usually one piece. It's almost as if you had a vase and it dropped it, and there was like one large piece that was off of the mouth of the vase. Whereas a pylon fracture, the vase would be in about 10 different pieces and involve the base of the vase. It's much more difficult to fix. The anatomical approach is much more dangerous. There's a much higher risk of complications such as osteomyelitis, infection, amputation. We both, I think, over 5 years, the orthopedic surgeons do more cases. The podiatrists definitely do more foot cases. They have not shown that they do more ankle cases, and they have not shown that they have done more ankle replacements or ankle pylon fractures. And I guarantee you that they have not done very many treatments of osteomyelitis of the tibial shaft from external fixation pins, which literally involves making an incision in the knee, going to the top of the tibia, drilling a hole in it, reaming down the entire tibial canal down to the ankle, aspirating it, and putting in a cement rod that contains antibiotics, and then coming back a few months later and taking care of it. Going to your second question, I mean, I think that, the smartest thing I heard all day was the comment about, a DPH, work group, a different one, to try to come up with compromise. That's what we did in 2005 and 2006. 2005, we agreed on the non-operative treatment of the ankle and what the ankle was. In 2007, we agreed with the surgery part. And the fact that, the podiatrists on the call are still angry about not being allowed to do pylons and ankle replacements, and the fact that most of the orthopedic surgeons on the call are still mad about them being allowed to do ankle fractures means that it's probably a good compromise because everyone's not happy. With respect to the various issues, I mean, I think the amputations, work somewhere between the increasing it to the level of the Chopard's joint and subtalar joint to the tibia. That can be worked out as long as the criteria of who can do that. Because with the amputation of the toes of the midfoot, there's not much tendon balancing. Once you start amputating near the ankle, you're cutting the tendons that help, bring the foot up and down and side to side. So it's important to understand tendon balancing. So that's something that I think, would be reasonable to compromise with respect to the better trained podiatrists. I think that could be worked out. With respect to pylon fractures, I think there's two things to be worked out. One is, what exactly is a pylon fracture? We proposed, one definition for it. Instead of compromising, they walked away. I think we need to define, what a pylon fracture is versus a post-traumatic fracture. And then we have to come up with criteria that comes up to which podiatrist in the state can do that. Because, as I tried to say before, of the two case logs we got, the one from St. Francis had 0 total ankles, 50 ankle fractures, and no pylons. The one from Yale had 2 implants that they were involved with, 48 ankle fractures, but didn't say how many pylon fractures. So we need to have more than just you finished your residency and then you can do these procedures without having been trained on them. Same with ankle replacements. You have to come up with some kind of criteria that allows you to do that. In 2007, we had some safeguards in there. We had board certification as opposed to board qualification for the more advanced ankle procedures, the ankle fractures, the fusions. And the difference between board qualifications is 3 years of residency versus, 3 years of residency plus another, 3 to 4 years of practice. You're getting to be 7 years. That's, equivalent to orthopedic training in length. We also had an advisory committee that reviewed case logs. In order to be able to do ankle fractures, you had to show that you'd actually done some ankle fractures, and you did that. So those protections are gone. So if we had a committee that could agree on those 3 things, which podiatrists can do amputations within the foot and where that level is, which podiatrists can do pylon fracture, what a pylon fracture is, and which podiatrists could do total ankle replacements, that would be the solution. I think that, the tibial diaphyseal stuff with respect to the external fixation pins, as in my handout shows, if you look at the anatomy, the ankle is defined as the distal tibial and fibular metatarsus and epiphysis. The area where those complications comes outside of the ankle. The only reason that podiatrists were allowed in the compromise in 2006 to put external fixation pins in that area because those are used to treat ankle disorders, like ankle arthritis and Charcot, not to treat tibial disorders, tibial shaft disorders. So that's kind of my long-winded answer.
This is a very helpful answer because it's giving us at least some insight into a path forward. And we'll probably have to have a little bit more in-depth conversation about this with you as well. I want to thank you for the time that you've taken end of your day after operating all day to help us. And then I'm going to follow up with you perhaps in the next 24 hours to get a better understanding. I know, Madam Chair.
Thank you, Senator Anwar. Next, our good ranking member, Representative Claritas Dietra, and I believe followed by Representative Parker, and I will have some questions as well.
Thank you, Madam Chair. Thank you, Doctor, for being here today. Can you let us know, I think you may have touched upon this, but just to reiterate, as an orthopedic surgeon coming right out of residency, what are the qualifications that they need to do to perform ankle replacement or those pilon fractures? What specifically do they have to do to qualify to be able to do that?
They would need to have a license to practice medicine in that particular state, and they would need hospital privileges to do so.
So what experience do they have with those specific procedures in their residency?
most orthopedic residents have experience in pylon fractures. A lot of them have replacement in total ankle replacement. They all have a lot of experience with respect to knee replacements, hip replacements, shoulder replacements, elbow replacements, where a lot of the same principles are involved in. You need to have fixation of a metal component to the bones on both sides of the joint, and you need some type of polyethylene liner in between that allows the smooth motion. So the principles need to be there. Furthermore, they've all had 5 years of training. And I think what's not been spoken here is that, part of being a surgeon is not just whether you operate on the foot or you operate on the knee. It's time. 5 years of working with patients, interacting with them, developing your surgical skills. As I think it was touched on before earlier by Dr. Gini, there's an enormous difference between a third-year orthopedic resident and a fifth-year orthopedic resident graduate, and these people on paper are just incredible, I think that applies to everything else. There's for podiatry, we talked about the 44 states that allow them to do ankle replacements now or pylon fractures. Well, first of all, those states do not include New York or Massachusetts. Second of all, most of those states do not differentiate between podiatrists who've had the ankle training associated with the RA, qualification or certification. It's just any podiatrist, off the street. A lot of those states also, 5 of those states allow podiatrists to do hand surgery. We need to do what's best for the people of Connecticut. So in order to do that, those cases for pylon fracture, there's probably not much, other than being credentialed at the hospital. Ankle replacement, you need to get privileges for that, and usually that would not be granted unless you had some experience in it.
Right, thank you. But to answer my question, there's not a certain number of surgeries that they have to perform on an ankle as orthopedic surgeons in their residency to qualify.
There's no fixed number in the residency guidelines that say you have to do 8 ankle fractures. You need to have adequate
0.
You need to have adequate exposure in all parts of the body, but there's no number, just like there's no number in podiatry to do that.
Thank you, doctor. Thank you, Mr. Chair.
Thank you. Rep. Parker.
Thank you, Madam Chair. Thanks, doctor, for being here. I have what I fear is a stupid question, but it's occurring to me from what you were sharing. There are folks that are coming out of these programs that have done 0 of these surgeries. But if they're not allowed to do those surgeries in the first place, how would they have gotten those numbers? Does my question make sense?
Yeah, no, it's not a stupid question. So they would either need to do those surgeries with orthopedic surgeons or podiatrists in the state who perform them. They would need to do a fellowship where they got experience with it, or they would need to almost like in the old bill before in 2006, 2007, have experience, scrubbing on those cases, with partners, what Dr. Kamenar, discussed. There is, Dr. Gambardella talked about, when people hadn't done before, they had to figure out how to do them on their own. Well, if you look at the literature, with even some of the best orthopedic surgeons, when they started doing them, they published the results of their first 30 cases, and the complications were high. I was at a national podiatric meeting, about 6-7 years ago, where one of their past presidents of the American College of Foot and Ankle Surgeons, basically, who's pretty good at it now, basically said, the first 25 I did, I messed up, and he didn't use the word messed. There's a learning curve, and part of the reason why we have residents and fellowships is that you learn from people who've done it before, so you don't make their mistakes, so your patients don't suffer. And I think, now that these procedures are well established, I think it's very important that the people who are doing these procedures have done them under the guidance of people who are experts at it and have learned, what's right and what's wrong and what the tricks are, as opposed to trying to figure it out on their own.
Sure, which is presumably how the orthopedic surgeons would learn themselves. So to your point before about trying to get a compromise, could you see a world in which there is whether it's a set number or whatever else of procedures that get done by podiatrists coming out of their school that then credential them to be able to perform these procedures? Is that something where they could get that practice, collaborating with someone, not to use a.
Yeah, I mean, if you look at the original bill back in 2007, it's basically does that. It's set up criteria. Well, actually, that and the associated regulations with it. There were regulations that were enacted that basically said how many cases you needed to do. There are cases, how many ankle fractures you had to do, how many ankle arthroscopies you had to do. And again, this is something that would not be determined by the orthopedic surgeons alone or by the podiatrists alone. It'd be a compromise.
And that bill didn't pass, the 2007 bill.
Yeah, so basically the 2007 bill was the product of a work group in 2006. I was on that committee. Bill Semina was on that committee. The podiatrists on that committee were Jim Nugent and Joseph Treadwell. Treadwell is also part of this committee. And we basically, came to a compromise. And, when the DPH report came out and there was agreement from, the orthopedic surgeons and the podiatrists, obviously it was an easy sell for the legislature to pass, and that's what happened. It happened the year before that with respect to the non-operative treatment of the ankle and definition of the ankle. So, so I think if there's a, agreement that a compromise that comes out, then instead of hearing, opposite, stories from both sides like today, you get people basically saying, okay, we're not completely thrilled with it, but we can live with it on both sides. So.
Thank you so much. We've got to learn more about that 2007 bill. Like the EDs. Okay, thanks.
Themes persist, don't they? Go ahead, Senator Amar. Go ahead.
Because I deal with another part of the body, I just want to know, pylon fracture, which one can podiatrists manage? Can you explain that again, please?
Yeah, so right now, podiatrists who have done a 2 or 3 year surgical residency, depending on when they graduated, and are either board qualified or board certified by the American Board of Foot and Ankle Surgery, can do malleolar fractures. And the ankle joint is made up of the talus, which is part of the foot, the fibula, which has the lateral malleolus, which is on the outside of the ankle, and the tibia, which has the medial malleolus on the inside of the ankle, and the weight-bearing surface in the center. Malleolar fractures involve the lateral malleolus, the medial malleolus, or the posterior malleolus. They don't involve the weight-bearing main insertion of the tibia. Podiatrists can do those. The ones that involve the weight-bearing surface of the tibia, those are the ones that they cannot do right now. And kind of the problem is, the exactly definition is not defined in the statute. So, there was one podiatrist who basically stated she had a, what was considered a pylon fracture, and she gave it away. There's other podiatrists who anecdotally have done pylon fractures and called them posterior malleolar fractures. So, I think if we're going to try to sell this once and for all, and we're going to have criteria saying which podiatrists, have enough specialized training to do pylon fractures, because they are significantly more difficult to do and they have a much higher complication rate than malleolar fractures, then you need to have a statutory definition that separates the two, that defines the two, so there's no ambiguity.
Okay, and is a CAT scan for these fractures a standard of testing before somebody intervenes?
So, a routine, bimalleolar fracture or a posterior malleolar fracture where the posterior malleolus is about 10% of the joint, you don't need a CAT scan for that. You can tell by the x-rays, what needs to be done. When there's involvement of the, articular surface, then a CAT scan helps because there's multiple little pieces inside the joint that you need to be aware of to A, fix them, and B, decide where you're going to make your incisions, because depending upon where the fracture is, sometimes you make an incision in the front and sometimes you make it, on the side, sometimes you make it on the back side. So, a good surgeon has a good plan going into what they're going to do. They need as much information as possible. And for a pylon fracture, a CT scan provides that information. For a routine bimalleolar, or trimalleolar, or just simple medial or loud malleolar fracture, X-rays are enough to allow you to appropriately plan.
Thank you so much. After this testimony today, I think I can probably apply for privileges to learn quite a bit. But thank you so much for your testimony.
Thank you very much. And just as a follow-up, Dr. Arno, so is the answer yes, it is the standard of care for that particular type of,
It's the standard of care for a pylon fracture.
okay,
It's not just necessarily the standard of care for a bimalleolar or a trimalleolar fracture. And if you're uncertain which one it is, then you're probably going to want to get a CAT scan to help determine that and help to treat it.
okay. I appreciate that. At 8:52 or so, I said to Senator Anwar, we have one more person and we have till 9 o'clock. And he said, I don't think that's happening. But Dr. Arno, I want to thank you. Your commentary, a lot of it, there are two doctors in the room, as we know, and I'm sure and confident that they were able to follow a lot of the specific anatomy conversation that you were having. And this speaks to what Representative Clara DeStitria mentioned, which is bringing everyone together. The scope review process brings together those of you who do follow this, right? We are the Public Health Committee, and there certainly are public health professionals or health professionals, but who deal with different parts of the body. So thus the process of coming together, we're here to hear from all of you. I will name that it's been a bit ironic for me today. I shared with my colleagues, some of them, that this morning at 7:30 a.m. I started out with my physical therapist, who encouraged me not to pay attention to my ankle today so that I could just be normal. So we've spent the entire day talking about our ankles. So it's been fun. But Dr. Arno, and to all of you who have testified all around this issue, we will be continuing the conversation. I want to also repeat what Senator Anwar said. Your testimony, which is extensive, does offer a number of references, which I would point out to fellow committee members is helpful to review. And we know that we'll be in touch with you. One last question for you. At the beginning of your testimony, you mentioned you're the current president of the
American Orthopedic Foot and Ankle Society.
And that's the national group.
It's actually an international group. We have 2,600 members throughout the world and 1,300 members in the United States.
Okay, thank you for that. Thank you very much for your testimony today. And Senator Gordon, for one very brief moment.
It won't even be a minute, I promise. So, Dr. Aronell, thank you for your testimony. And I just wanted to get a quick clarification because it was asked about whether or not getting podiatrists and orthopedic surgeons together, we could try to see where there could be consensus and common ground. Do you think that that's something that could be done to see what could be hashed out medically as far as who can do what and how one does it in order to try to come up with consensus amongst some of the experts?
We did it in 2006 and 2007 in Connecticut. We did it in 2017 with respect to the VA and national legislation on a compromise to allow podiatrists to be paid higher in the military and get leadership positions without being called physicians. And we've also done it on a task force, which Dr. DeHeer is also on, about a process that podiatrists should be universally considered physicians. So it happens. You just need to get people to sit down and talk and be reasonable about things and respectfully disagree and look for compromise and usually you can come up with something that neither side's happy but they both can live with. So
Thank you, Senator Gordon. Thank you, Dr. Arno. As we conclude our public hearing today, I want to say a special thanks to our behind the scenes team who always helps get us through. We are very fortunate to have all of them. Thank you to all of the members of the public who stayed with us throughout the day. And to you, our fellow committee members, we are grateful for your attentiveness diligence, and we look forward to continuing the conversation. With that, we are adjourned.
Okay, see, Peter,